Brilliant. So, hello everyone, and welcome to the first TIA Centre seminar of the academic year. For those of you that are new to our seminars, we invite researchers and leaders in the area of computational pathology and associated areas to discuss their work. And today, I'm particularly delighted to introduce Dr. Nadieh Khalili. Dr. Nadieh is an assistant professor in AI at Radboud UMC, where she leads research at the intersection of deep learning, digital pathology, and multimodal data integration. Her work focused on developing clinically meaningful AI tools for cancer diagnosis and treatment response prediction. She has a background in biomedical engineering and previously worked in R&D roles in industry. She is also actively involved in organising scientific events and is a board member of ESDIP. And the title of Nadieh's talk today is Towards Multimodal AI for Personalised Cancer Treatment. So Nadieh, thank you very much for joining us, and we're really excited to hear about your work.
Thank you so much, Adam, for inviting me, and also the TIA team. It's my pleasure to present. Yeah, as you said, it's about the multimodal AI for precision oncology with a little bit of insight for the CHIMERA benchmark. Please feel free to interrupt me anytime that you have questions. I would like to be interactive as much as possible.
Brilliant. Thank you, Nadieh.
So, sure. Like Adam mentioned, I have a background in medical imaging, deep learning, and specifically my PhD was in the radiology. And after that, I joined the industry, which was a context vision company, Swedish company in pathology. And then later, I came back to academia. And what was actually a strike I was noticing a lot was that we are treating, especially the cancer patients, very much fragmented and in a silo, where we are having in a hospital pathology department, radiology department, where they are gathering gray data pathology, which maybe you're more familiar with, is a lot of H&E, pinkish, and purplish images with immunohistochemistry, etc. And is also similar for the omics data when we are having RNA, DNA sequencing. And each of them, they have very different dimension of the data. They are quite heterogeneous, etc., which we are diving to more. But it feels that we are repeating the same in the history in AI too. Where we are collecting lots of data and we are training the model in solio, in pathology, in radiology, in omics data. And we are putting somehow a lock on each of these models and hoping that they are able to combine at some point and able to find out where is the disparity and where is the alignment. In 2024, many papers has been published for foundational model, specifically in the pathology. There was many models that you are aware of very well. They were in published in many Nature journal, and it was similar for DNA. There was DNA, BERT, etc., that they were trained on billion of data and released the foundational model. And also similarly for the radiology, where they were trained on a million of data, and very, very few of this paper, they were actually trained on a pair data set. When they actually use a pair of, for instance, this was one of the few one that was trained on the pair of the foundation pathology and radiology data, and it was specifically for the prostate cancer. We also had, we made a multimodal AI review paper when we published it last year. And we highlighted two main points that was so far missing. Firstly, we noticed that the lack of data in the multimodal is serious. There is a lack of paired data set. And secondly, there is a technology innovation which is lacking. I will dive into it a little bit more. There is a lot of variability in patient care pathway, often resulting in incomplete data. when a patient is acquiring the first node, for instance, if it is the prostate cancer, it comes with a PSA value, and then later they may have a biopsy, an MRI, and maybe they have it in the different hospital, in the paroxy hospital, and then they are coming to another hospital for other data set. And it's very difficult to have always very complete set of data, which are completely paired from the one patient. And even if they are in one hospital, very simple logistic problem like anonymization from one department to other departments has been done very differently that make it very challenging to be able to pair all of these data sets. And from the other perspective, like people like us who are the AI scientists, we are also not having the perfect solution to be able to fulfill this data set. When there is one missing data, can we actually impute it? Can we actually impute in a way that is generalized very well? These data sets often are having a very different modality, with very different dimension, and impute them or generate them doesn't necessarily complete the picture, and the AI is also not yet advanced to be able to do. Therefore, and the last challenge is also that after all of this, we are also need to infuse all this information in a one embedding to be able to have some interpretation. If we are having an MRI, which is a 3D images, pathology, which is the gigabyte of the data in 2D, and then we are having a clinical data, which is a tabular data with certain values. And if you have omics data, is also perhaps like a textbook. Each of them have very different dimensionality, and is also very difficult to think of a very classical fusion model, whether to make a choice and what is the best practice for that. To be able to bring a little bit of more clinical aspect to it, one of the, perhaps you know that 2018, the winner of the Nobel Prize went to the immunotherapy for the medicine. For the first time, we could find out a treatment that's not fighting to cancer cell, but be able to activate our own immune system to recognize the cancer cells. But it's still very, very tricky to be able to find out which patient are able to benefit from immunotherapy, and it's also a question in oncology. One of the very, very well-known biomarker that we know often respond very well to immunotherapy is microsatellite instability. Microsatellite instability is a situation of DNA that produce perhaps many, many more mutations that is more visible to the immune system, and therefore the immunotherapy work better for these patients. And in the clinic so far, we are doing immunohistochemistry to stratify MSI patients in early for colorectal and endometrial. And these are two cancer that has quite high prevalence of MSI high, where it is actually correlated to immunotherapy too. As you can see, 30% of endometrial patients, endometrial cancer, they have MSI high. Colorectal also about more than 10%, depends on the literature. But the rest of the cancer, there are also between 2 to 3% of microsatellite instability high. But we are not doing any tests in clinical routine, at least not in the Netherlands, unless there is some sort of trials. And this patient can also benefit from immunotherapy. But it's logistically very expensive to test immunohistochemistry for such a high population to find out 2 to 3% of the patient who may benefit from the immunotherapy. And it is very impossible infeasible, and is also expensive to do. So this is actually where AI can play a very good role to be able to stratify these patients early on, because the pathology slide is already available in the clinic for free. And the AI is able to detect MSI high. There are many literature has been showing, at least in the colorectal endometrial, with a very high AUC curve, we could detect the MSI directly from the H&E slide. And then later we can also gather more information like whole exome sequencing, combine it with the whole slide images, and then have some sort of treatment response to immunotherapy or other therapy of the choice. This is one of the examples to show that how in clinic we can use of this multimodal model that we can use, and is already something that is not very futuristic and feasible. Highlighting all these challenges, if you know our team, you know us for our challenges. You know panda, you know perhaps leopard, chameleon, monkey, and we have team of animals. So if it is coming to multimodal, we also need a multimodal animal, that is the multi-animal. So we came up with the CHIMERA, which is combining histology, medical imaging, and molecular data for medical prognosis and diagnosis. So we organized for Mikhail last year, few weeks ago, the CHIMERA challenge, which included 3 different tasks. I quickly go through it and then I explain further. The first task was combining MRI together with the pathology for detecting or predicting the biochemical recurrence. The second task was the bladder cancer for prediction of BCG, which is a treatment response. And the last one was on bladder cancer recurrent prediction, combining together RNA sequencing and pathology slides. If a patient, this is actually very demonstration of the how patient's journey is, how prostate cancer patient journey is in the hospital. Firstly, perhaps they are acquiring PSA value, and then biopsies, and then following by also MRI and biopsies. And then if the Gleason grade is higher than certain number, they are deciding to do prostatectomy. They are removing the prostate. And if you are familiar with the prostatectomy histopathology, there are many of the slides that are scanned, and then followed by that, they are acquiring PSA value consecutively. And if it is higher than certain threshold, it is detected as a biochemical recurrence. For the task 1 of CHIMERA, we have selected prostatectomy together with the prostatectomy H&E slide, to be precise, together with the MRI. And then we ask the participant to predict PSA level after surgery or biochemical recurrence, whether it is positive or negative. We also introduced, we also added a lot of clinical data. We ask actually pathologists to extract many detailed clinical data from some of it was from the report itself, but also a lot of it is not necessarily always available in the report. Things like AJAS prostatectomy, primary Gleason grading, secondary Gleason grading, ISAP, and lymph node invasion, if it is happening or if it is available or not, etc. And this was also available in the first task as a clinical data. And we were kind of designing or assuming that all the participants will have a pre-trained encoder for the pathology slides that was available, and then a pre-trained encoding for the radiology slide. In fact, we also put some of all the features also available from the foundational model. And then There is also a clinical data that can use simple MLP to concatenate all this modality together using some fusion and then classifying for the time to recurrent. I want to jump to the result because, oh, I see that it looks a little bit different, but I think it's still visible. I think if you are in MICAI, you perhaps know this already. And surprisingly, the first three rank, they only use the clinical data. And it shows that and the fourth and fifth, and they also use the multimodal. They use all the three modality that was available. If you look at the number, they are relatively close to each other, but the clinical data could definitely get better performance than others. And it shows to us that even though we are having many achievements in AI, we are still lacking, or maybe in the time that we put the time pressure that we had, it was very challenging to be able to develop something that is extracting all meaningful information from all this modality to get even better performance and compared to what it is already in the clinic available. And however, each of these clinical data, as I mentioned earlier, we provide them, but is not always available in the realistic clinical setting. At least they are not as clean as we provided in Excel sheet as a tabular data. And then the second task that we had was the bladder cancer BCG treatment response. In the bladder cancer, when the patient is diagnosed as a non-invasive bladder cancer, they are often taking a sample, which is as a biopsy from the bladder. And if it is diagnosed as a non-invasive, they are injecting a vaccine that is called BCG. And so far, there is not much of understanding which patient are actually responding to this, or which patient develop recurrent after, and it become maybe invasive bladder cancer that grows to the muscle. And this is already quite vague, and some of the biomarker that is developed showing that certain class of the patient may respond or may not respond to it. And one of it is BRS, which is from my collaborator in Erasmus. And this BRS is actually derived from the RNA sequencing. It's classified based on the RNA sequencing, whether certain genes are present. It classifies as a BRS 1, 2, or 3. And as you can imagine, in the all clinical setting, the RNA sequencing is not available and is also very expensive to acquire for all patients. So it's actually very clinically relevant to be able to predict BRS value directly from whole slide images, which is always available. This is also a survival based on the classification of the BRS. You can see there is a distinguish with the BRS 3 and BRS 1 and 2. So BRS 3 did respond way less, and then we also made it as a binary prediction for task 2, whether this whole slide image BRS 1, 2, and 3. So it was a binary question of BRS 3 vs the rest. We also provided relevant clinical information like age, sex, smoking is also relevant for bladder cancer, stage, etc. And this is also similar baseline that we also developed based on the very data that we had. And if you look at the results, it was actually very promising in compared to what is already available in the literature. We could compete with the best result, and the AUC curve of the participants was higher, not us. 0.73 was the highest, and then followed by the others. And F1 value was the metric that we have used for evaluating the leaderboard. And the task 3 was similar data, and then we also provide the RNA sequencing, and we ask the participant to predict the recurrent, whether it is developed to invasive bladder cancer or not. It's a follow-up of 5 years that they are looking back, and we had the nice data set to be able to do. And surprisingly, the winner of the task 3 also only used the clinical data, and the second and third rank, they use multimodal for prediction of the recurrence. And what is actually interesting to also look was that when they were using very light-weighted fusion approach, it was achieving better result, which can be also interpreted as we had a limited amount of data, and having very high-weighted fusion can also overfit easier to the data in compared to the data set we have, which can be also one of the challenges. So as you can see, CHIMERA maybe didn't actually solve the multimodal AI in challenging and multimodal challenges, but it was moved the field as one step further, and we are really looking forward to look into each algorithm more in detail. We are very fresh now coming back from MICAI, but we are going to look into whether each of these clinical data, how much effect it has in the actual recurrence, and whether if we are combining data, is it also less challenging if one of these data is missing, one of the clinical data is missing. So this is something that we are working currently on. And the bottleneck is always stays that the paired data set is very rare, and the reason that we had for each of the tasks maybe 300 data, still very first multimodal data that is openly available, but also not very, very high amount of data to be able to use very competitive and models on it. And the reality is that this clinical data that we have provided is very powerful, and it shows that is actually this clinical values are relevant, but it's also very messy. You cannot in the clinical setting find this easily. And data fusion is also a future that we have to work, and some people in our group are also focusing specifically on that subject, because we find out it's very tricky to find very good fitted data fusion that can be combine all this modality together. And this was also impossible to do without all these people. We were quite large team from January working hard on the data curation, and also we had a lot of pathologists, radiologists working next to us to be able to have meaningful question, and also curating very accurate clinical data too. I would like to thank you so much for attention, and I'm really happy to get any question.
That's fantastic. Thank you so much there, Nadieh, for a really, really interesting talk. And well done again on such a great job with organising the CHIMERA Challenge as well. So yeah, with that, should we open the floor to questions? Has anyone got any questions they'd like to kick off with, either online or in person?
I can ask a question.
Yeah, go for it, Mustafa.
Yeah, thanks, Nadieh, for the amazing talk and also a successful challenge. I think it's really valuable. These data sets, especially, hopefully stays on and people can still use the data and also being able to do submissions after the challenge, in our experience, that also can be very effective to come up with better solutions. So you, in your talk, you mentioned for two of the tasks, people using only clinical data were the most successful approaches, right? So I was wondering what factors in the clinical data were more impactful on those predictions. Have they reported anything specific, or say any report on which parameters have shown more relevance to the task?
Thanks for the question. It's actually a very nice question, and that's exactly what we would like to focus on when we are gathering more from all the participants. I can show for each task, this was what we had from bladder cancer. There was no submission that has a specifically explainability factor to show that this is a specifically very important, but it's something that we definitely going to highlight in the paper that we are writing, that which parameter are the most important for prediction. I can imagine that a lot of the the current parameter, like a staging and all the things that medical medicine is based on, is already very important factor, but I don't have the answer, but it's very interesting. But yes,
That's true. Yeah. Hopefully in the post-challenge publication, it will be really nice to see some of this. Yeah, well done again. Thank you.
Sure.
Brilliant. We've also got a question from Jachi from our centre online as well. So he was asked, what's your view on developing models to first predict clinical data from pathology, radiology, or gene data, for instance, and then predicting survival from clinical data? So this sort of two-stage pipeline.
Exactly. That's a very good question, and something that can be maybe more realistic than what we are having here, because it's firstly, you're using those downstream tasks to predict the clinical data. Maybe it is working more in better way than to fuse all of them together. It is it's something that we have to see what is going to be when those data are not available, because now all of the three modality was available and was not challenging enough for the participant to come up with such a solution. But I'm also very curious. Yeah.
Thank you. I've also got a question as well about sort of explainability/interpretability. So sort of traditionally with pathology, having these sort of multiple instance learning pipelines, or even the foundation models now, there's always a worry about interpretability or explainability. But at least with sort of pathology and using just a single modality, you can still pull out heat maps and we use sort of attention for that. But when we go multimodal and we start doing fusion, and you've got sort of cross attention and all sorts of different things going on, how do you think that then impacts like final interpretability and I suppose trust from clinicians as well?
Yeah, it's a very good question. I think for sure the question perhaps become more complicated to interpret which data set, but I see very few things that is developing in that direction to be able to find if we can find the similarity in the embedding from each of the modality and be able to similarly as the images also be able to apply it in the tabular data. I can imagine that's also not very complicated task. So we have in the pathology, we can look into the attention map, and for the tabular data, we can also look at which weight is activated. Is not developed in a way that we can just do it ad hoc, and it's something that we have to work on it more. And for the task 2 of the CHIMERA, we also provided because when you're extracting the RNA sequencing, I can maybe bring one slide that we had here. Mm. The RNA sequencing, how they are acquiring in clinic is that they are annotating one area on the slide, and then they are acquiring RNA sequencing from the highest grade of this patients, for instance, this region. And we also provide this annotation to be used as a explainability. Unfortunately, it was not perhaps enough time that people really use this, but it could have been very interesting to see, can we actually use this as an interpretability, and then look if the RNA sequencing that the way that we are doing it in the clinic, is it relevant already? Or is it also other regions that are also relevant? So yeah, these are the questions that we can further answer in future.
Brilliant. Thank you, Nadieh. And do we have any other questions from anyone?
I've got a comment, not a question. Nadieh, first, Fayaz here. First of all, nicely done, the challenge. I was hearing very good updates from the team here at Warwick. And I've got a perspective, not so as much a question. I think being able to predict an outcome from clinical variables is nice, but there's nothing you can do about it, right? So if, for example, gender or age comes out as the most important feature, there's nothing we can do to change it. However, on the other hand, when you've got other modalities like proteomics or spatial transcriptomics or transcriptomics, and we find that the gene expression of two genes is different, now that is something we can do something about, right? We can design a drug that we can give to the patient. So I feel like being able to predict levels of survival is nice, but where does that leave us? We already have in your clinical data, you could see that you got grade and you had stage. All that information was already there, though it was inferred from humans, assigned by humans, pathologists. But at the same time, what are the drivers of those factors is more important to understand, and that is clinically or pharmacologically actionable. What do you think of that?
That's actually a very good remark. Yeah, that we are actually can derive from the clinical data something that we don't already have in the clinical setting. What you're referring is to if we want to have a new biomarker, that's what we can step out, right? That's from the RNA sequencing, finding that this set of genes are necessary answering to certain new treatment, or there are already new biomarker that is relevant and calling for a new treatment. I agree totally that what you're referring to. And
Go ahead, please.
And I hope that with the multimodal, we step to that indeed, that we just go one step further than what we are already have as a practice.
I've got a suggestion on top of that. Like, I think with this type of multimodal data, it would be really useful to identify what subgroup of patients, what are the clinical attributes of patients in which we can use, for example, histopathology, whole slide images, or we can use transcriptomics. What are those subgroup of patients for which we can predict survival very well? And what are the drivers? What are the differences in transcriptomic profiles? And what are those clinical features? So is there a group of females above the age of 60, for example, that have, in which case we can always use genome sequencing, for example, or profiles to predict their survival? Because if that is the case, then what we can do is we can identify those differences and make a recommendation on top of that. So in your follow-up analysis in the paper, my suggestion, it's a very humble suggestion, if I know the paper would be quite large already with all the submissions that you've had, but I think that would give it a very clinically translatable angle. So can we identify subgroup analysis that would be useful clinically down the road?
Thank you for suggestion. It's very relevant. We perhaps also need a little bit more that indeed to show that because we don't always have the RNA sequencing for instance, for the task 1, it was only pathology and radiology data. But for the task 3, we can look into that way more indeed. Yeah. It's a good suggestion. Yeah. Thank
Brilliant.
you.
Thanks for that. So do you have any questions from anyone else in the room? I see there's also a question from, I think, Serson online, who's also asking about explainability. So I think from my understanding was that, Nadieh, you said that you hadn't managed to explore for instance, the clinical data yet, which was the most predictive yet. And then we've also got Nasira said, nice work. So yeah.
Thanks.
Fantastic then. So if no one else has got any, actually I had a question. So one thing from when our group was looking at particularly task 1 was that we really struggled to find basically any sort of predictive signal using the radiology data. And we wanted to know whether that was just us or if anyone else also had this problem.
What we are hoping for was that you can actually look into beyond what you see in the prostatectomy from the radiology. How far is it from for instance, for lymph node invasion, etc. And maybe those questions was already in the tabular data. That's the radiologist already made it a remark that there is a lymph node invasion in this patient, etc. So maybe the signal that you would not taking necessary from the radiology was already presented in the clinical data. But I don't have very, very clear answer until we do the full interpretation from this.
Sure. No, well, thank you very much, Nadieh. I think if there's no more questions online or in person, I think we'll call the seminar to a close there. But again, Nadieh, thank you very much for a really great talk there and for sparing your time to talk to us.
Thank you so much for having me. It was really a pleasure.
Thank you. And a bit of a reminder for everyone else, we've got our next seminar is in 2 weeks on the 27th of October, which is going to be held by Dr. Rohan Chakraborty from UCL, where he's going to discuss his work on conformal quantification of predictive uncertainty in health AI. So hope to see you all there. But thank you very much, Nadieh, and thank you everyone online and in person for joining us. Brilliant. Bye, everyone.
Thank you. Bye.